like to introduce our first panel. We've deliberately chosen a group of disruptors, each of whom represents different parts of the health ecosystem. So we have Caroline Smith from Nuffield Health in the UK, which is a private healthcare provider that's doing some interesting things in terms of fostering wellness with their investments, and I'll let her tell you about those. Tripp Jennings leads innovation for BlueCross BlueShield of South Carolina, and they're very much pursuing a data-driven strategy to accomplish their strategic goals. Jean Olive is the CTO for Best Buy Health. For those of you from outside the US, Best Buy Health is one of the largest retailers of electronics in the US, and they're really, I think of them as one of the most disruptive companies I've dealt with because they're really moving into the healthcare space in some really intriguing ways to enable care outside of the traditional hospital setting. And then Jason Teeple from Evernorth Health Services is leading the strategic interoperability approach that Evernorth is taking. Evernorth is the health services arm of Cigna. Full disclosure, my daughter works for one of their companies. They're looking at how they use data to pursue their strategy. So each of them has some really interesting approaches to what they're doing. They're all leveraging data, and Claudia is going to take us through a conversation with them.
Perfect.
Divided up, didn't we?
You did good. I guess I'm the, we'll get the women and the men. Well, it's so great to have you. It's fun to be here in real life as opposed to the phone. And as just a way to kind of get to know each other, if each of you could share one thing about your company or organization that is important but most people don't know. And we'll start over here.
Hiya, Caroline Smith. Come over from the UK today. Thank you very much, InterSystems, for inviting me. We are the UK's largest trading charity, which is a really interesting place to be. We have hospitals and wellbeing centres, fitness and wellbeing centres. So we've got a unique set of capabilities and assets that we can bring about this kind of disruptive shift, I suppose, into we are now creating what we're calling healthcare systems facing into communities. So yeah, we're just on that journey. We started last year changing our operating model.
That's awesome. So I think probably most people in this room know Best Buy, but may not know Best Buy Health. Best Buy Health is a digital, we're building a digital platform to really enable wellness at home, aging at home, and then care at home, so we can enable care at home for everyone. What I don't know if everybody knows, Best Buy is really doing a lot with health equity, with equity and health equity, and we have teen tech centers. We have 54 to date with a goal to build 100 by the end of 2024, and we've recently partnered with Atrium and just built a new one in North Carolina where we're actually having virtual clinics. And it's not just the teen techs too, we're also bringing the aging community in to work with the teen. The teens actually help the aging community. So it's something that Best Buy is very focused on giving back to the communities and to really bringing tech in the home and tech as an enabler for our rising youth.
Great. Yeah.
Tripp Jennings, BlueCross BlueShield of South Carolina. So something unique about the company, I think South Carolina has 6 million so odd lives in the state. And so many years ago, we leveraged, way before I was part of the team, technology play to say, okay, you can only get so big if you only got this many people in the state. And so started to develop other lines of business and other businesses to be really kind of almost 40 different companies under one umbrella. And our government side of the house actually processes the majority of Medicare and Medicaid, as well as all of TRICARE now. Sometimes we're the back office for several other Blue plans as well. And so it's a big company, which is one of the reasons why it's a small company with a lot of data, is the way I should say.
We'll be back to that.
Exactly.
I am Jason Teeple from Evernorth. I get asked this question a lot. What is Evernorth? It's hard to answer because it's a new
I
company.
have to look you guys up.
Oh yeah, I did too before I showed up. So we actually we're uniquely positioned because we're at the center of being able to provision care from a virtual standpoint, from an in-person standpoint, and we also have a large pharmacy facility. So we have behavioral programs, we have clinical programs, and we're at the center of being able to connect all those experiences together to drive a unique customer experience that drives, hopefully better outcomes.
Great. Well, that's so exciting. Lots to dig into. Each of you in your organizations is a technology innovator and disruptor. And I think one of the things I think about with that word is helping us move faster to solutions that work, right? Helping us take away the barriers and move faster. And I'd love for you to share something that you think could be helpful to everyone in this room about how to move faster. Because I think we are all in healthcare. Fast is not the thing we often, in fact, people often say slow is better than fast, right? But yet we have such urgent problems. So what is something you've learned about moving faster towards solutions that would be helpful?
Sure, I'll start. So the first thing I would say is take the risk. If you are a business owner or a business leader and you have the ability to actually make a decision, take the risk. That's the biggest barrier that we have in our house, is getting people to be willing to take the risk. They hear interoperability, think it's a magic solution. It's not a magic solution. It's just an enabler for something to happen down the road. We don't deliver value to someone. We enable value. It's for someone else to make that determination. But the biggest hurdle is just taking the risk. And what I would say is, if you can't take the risk, be small and nimble and move quickly, essentially under the cover of night. And that's how we, from our standpoint, how we got going. We got a lot of visibility once we start showing, well, we did this for a few $100s. We did this for a few $100,000.
So ask for forgiveness, not permission.
Exactly, just move forward.
I'd agree with Jason. It's take the step.
Yes.
Take the step. When we were going to do our operating model shift, we took a long time thinking about it, and actually we then just said, right, good is good enough. Got enough data, it's good enough. Let's take the step, and then don't do it solo. If you're going to disrupt, don't do it solo. And it's no surprise I'm here today having a look at HealthShare, because it's very tempting to try and do it all yourself. Don't do that. Have a look at the guys out there and the providers out there who do it better than you do. Who's the best in class at doing that kind of stuff? And then select your partners and select them carefully, because there's too much to do to do it all on your own.
So one comment. It's very easy for all of us to look to want to have the silver bullet, and we say this on our team, and for goodness sake, we don't have it figured out. This is just one of the things that I think has helped us, is how do you go beyond, the statement of, interoperability, and you say that to people, that's not the magic bullet. It's what we're going to do with that. It's the intervention. And one of the things that we've looked at is really behavioral economics of the leadership. And so if we find something that we feel like is the right answer, but a great solution, if nobody adopts it, or if your leadership's not on board to even try it out, it doesn't go anywhere. And so trying to help to ensure that on the front end of adoption, we're looking at the people who make the decisions. My wife knows how to get me to do anything she wants me to do. And even if I don't want to do it, she'll figure it out. Just have that kind of thought process as we try to implement these things, even if it's on a small trial, just to say, you have to know the people that you're trying to work with. So.
And to that, I remember one of the experiences I had was working in the White House with Todd Park when he was CTO, and he launched the Presidential Innovation Fellows. And he would always, these brilliant people who would come in from every kind of technology company and kind of come in with the real just feeling like now that they were here, things were going to happen. Mm-hmm. And he gave the best advice. He said, no matter how novel you think your idea is, somebody else had it in that department. Your job is to find them and give them the wings so that it can come from within. And I saw so many people have to learn that lesson again when they forgot to do that. But I think so if you're coming in with an innovation team, like embed those innovators with other people throughout the company that have wanted to do the same thing, but maybe didn't have the resources or didn't have the kind of air cover to do it before. Yeah. So COVID, I think, was a time when we were all surprised by how quickly things did move, and in ways that saved lives, right? Whether that was telehealth or getting vaccines approved and on the street. We also saw a lot of glaring problems that were really put into sharp focus because of the issues of equity, of access, and everything else. I'd love, what is something from COVID you wish had stuck? Like that actually, what is an innovation or something that emerged during that period that you think really could have been expanded?
I think some of the waivers, the CMS waiver, especially for hospital home, I mean, it went fast. I really think that not even hospital home, but care at home, whatever it may be, a post-acute care at home, to give our providers and our physicians, illuminate that dark side of the moon. When people leave the hospital, they still need to be managed and monitored, and I also think it will really change behaviors because, health is far much more than healthcare, right? And if you know that every day you need to step on that digital scale, then it's going to be recorded and your doctor is going to be able to see it and it's managed and monitored, you probably will be healthier, right? Or your steps are going to be measured, right? Your blood pressure is going to be measured. And then if you can do it for 6 weeks, then it becomes a habit. And if it's a habit, you'll try to take better care at home. And then it gives you the aperture too to see these inequities that so many people experiences. We're leveraging Geek Squad to go in and set up, because one of the biggest challenges with remote patient monitoring is setting the tech up. And there's places that they have to clear a way to go in for people to go to the bathroom. Like I don't think so many of us don't know these inequities that people face, especially our aging community, right? That people face each and every day. So I think we were on a great path. Like, how can we stop some of the, get the waivers, make these decisions and say, this is how we need to enable care outside of the hospitals, because the hospitals can't do it all. Mm-hmm. And we can't afford to keep building hospitals with the beds. Someone said a couple weeks ago, it's an average of $1 million per bed in a hospital to build a new one. And that's not, people want to be home, right? You want to be home, you eat better, you move more, you sleep better, you're with your family, you're with your pets. That's what's really important. If you can be at home, can't be everybody, but when you can be.
Yeah, and I think that breaking down the barriers we saw in COVID, I don't know whether you saw it here in the States, we saw the barriers starting to be broken down for data sharing because we had to, and we had to do it fast. So that agility was really interesting. It's retrenched a bit, which is a bit disappointing, but we're pushing back into that now as to how the independent sector works alongside our NHS, so that we get that greater visibility and that sharing and being able to see full scopes of practice, be able to see the patients more clearly. That I wish we could have continued that track and not retrenched. That was a shame. But some of the stuff has stuck in terms of pushing care closer to the patient's home, because we have care going on in our fitness and wellbeing sites, which is just great to see. You're quite right. They want it near their home, don't they? As close as you can get to that, or in a community environment that they recognise, and therefore recognise us better as a provider that can help them, because our brand Stretch struggles with that a bit. So we're having to push into communities.
Yeah, I'd like to add on to that. One thing that, take the politics out of this, but the vaccine cards, right? The immunization records. Just last week, I had to go for both of my children to get their immunization records so they can go to a camp. If I could just send them the card, that would have been so much easier versus having to go into the portal, print it, take it to the provider office, make sure it was okay. It was a waste of time. When all it could have been is just, okay, I'm sending it to this email address and forward it. It would have been so much easier. And we, for some reason, decided to get away from that. It's unfortunate.
So we only have 30 minutes, so I'm not going to bring up work from home as the...
no, not today.
Yeah. So...
it's a good point, though.
Yeah, it is. It's interesting. And I'll say, there's so many things good and bad. Maybe not what stuck, but one of the things that I think broke the log jam and woke people up a little bit was really when providers on the ambulatory side, they weren't open and they weren't making money. Forget about some of the federal funds that were coming in. They were like, well, wait a minute. How am I going to stay in existence if people aren't coming in sick? And it was like, well, we've been saying this for years. We're trying to keep people healthy. Mm-hmm. So that really did. We saw a significant increase in the number across the nation of providers starting to say, okay, maybe I do need to ask some questions about this. Mm-hmm. And so has there been a massive surge in value-based care? I mean, I can't say that. There definitely has been an increase if you look at the numbers, but there's been an improvement in the attitude because people were dealt with that reality.
Yeah,
so.
Great point. One of the questions we talked about in the prep call is I said, what percentage of your job is technology versus business? And basically all of them said it's both. Like that is what we do as technology strategists. We are driving the business goals. And so one of the questions that was occurring to me is, what is a business goal that's really important to your organization where you are really lacking the data you need, and what are you doing to fill that gap?
Sure, I'll go with that one first. HEDIS is probably the biggest challenge, right? Because that is a hand-to-hand combat situation where you have to go into the provider's office and print out the charts. That's a time suck. And to be able to enable that through an interoperable channel where the pathway is certified makes a lot of sense. But to be able to do that, you need to have the infrastructure in place, and I won't get too technical, but you need to have the infrastructure in place to be able to connect from provider to provider, payer to payer, and then back to CMS. So there's a lot of challenges there, and I think that's the biggest area for opportunity from a payer side and from a services side is connecting to the provider organizations, getting out of their way, because we get in their way, right? When we have to go in there and we have to chase the charts, we're taking up a seat, and I think that's a great opportunity.
And I don't know how many HIEs are in the room that are DAF certified by NCQA to provide, or on the pathway to DAF. I know, Emma, that was a huge initiative of a lot of health information sharing networks, HIEs, is to actually make that collective data certified. And I'm telling you, there were many hairs lost over that process.
Absolutely.
Yes. Other examples?
Yes, I don't even know where to start. I think back when, this is several years ago, we started to look at, how do we solve some of these complex problems? We try to break it down and say, what are the 5 whys? How do you get down to the root cause of what's needed? And then we built some goals, strategic goals around that. And when you're within a payer, even from a clinical standpoint, but I was a chief value officer and CMI over a large health system, so I knew what some of this stuff was, but you come into a payer and you start talking about ADTs and CCDs and ORUs, and they're like, what?
I've had that. I've been there. In that room.
Much less, I want a strategic goal that's going to predicate your incentive around this, and we have to go out. And they're like, well, how are we going to control the hospitals? I was like, well, we have this little thing called money and how much we pay them. We can work this out. And so one of the first ones was really just starting to socialize ADTs by saying this is going to be a strategic goal to build those foundations. And it sounds almost silly to a room that works with this stuff all the time, but for the sports fans, it's like this is a basketball. That's where it starts. It really starts at understanding what you're trying to do, and so that's kind of what we've done. We've tried to build on that every single year to the point that now it's part of our contracts. Mm-hmm. So when we go through renegotiations, it is part of our contracts that's in there to say if you're going to do this, you have to send clinical data.
Mm-hmm. Great example.
Yeah, we were more building on, I suppose our lens was, particularly as we came out of COVID, being really clear about what our value proposition is. And as we started to join our bits of our business together and truly try and offer connected healthcare, is you've got to start to think end to end. So what's that whole customer experience end to end? And then what data's got to underpin that to tell you that either is working or isn't working. So, what are those classic journeys? How do I book with you? How do I pay you? All those journeys, just understanding those. So it was a key goal of ours was to really get our heads around that and be clear as to what we were offering to what we call them beneficiaries, because we're a trading charity. So it's our customers, our patients, everybody that interacts with us. And then, what are those customer journeys and do they work? And we're on journey number 2, I think, of 15. So we've got some way to go.
Yeah, I remember we worked with 13 health plans at Manifest MedX, and a large plan had a huge innovation budget to do all these really awesome things. And then the next meeting I had with them, they said, we're not doing any of that. And I said, you're not? Well, I don't know, we were kind of looking forward to working with you. And they said, no, we're fixing claims. Like, we're fixing customers getting answers to their questions when they call and whether claims get paid. And then we'll be back to this other stuff once we fix those. And I think that is one of those balances that's hard, is we have to be investing in innovation, but if the foundation's rotten, then nobody really trusts you to be a good partner.
It's that balance of go slow to go fast, isn't it? It's always quite tricky as to how to keep the innovation going, but you've got to lay it over some solid track. Otherwise, things get quite difficult. Jason and I were talking about it's the non-sexy stuff that's actually so important to try to disrupt with data and innovation. Because if you do that over broken track, your workforce become pretty tired quite fast. So, but it's hard. That is hard.
And also, it sometimes involves admitting that you have a problem with something that, like, your board thought you'd already fixed. Like, it's like, oh no, we're still working on that claims problem, sorry. So there was a great quote in our prep call, and I can't, one of you can claim this, but which was, data quality is a flaming pile of trash.
Yeah, sorry, yeah.
And I think we could all relate to that.
I was trying to be clean, too.
Was that you?
Yes, yeah.
Okay,
I was trying to be nice.
we could sub in trash or something.
Yeah.
And I think we've all been there, right? We know that there's so many problems with data quality. We know that we can't fix it on our own because it's a collective problem, and we know we can't boil the ocean. So I guess what I'd love for you to share is what is within reach that we're not doing? Like, what should everyone be doing that's not like semantic interoperability in the sky that everyone, but like, what is the next thing we should be doing that's gonna make this a little bit better?
I think we could be talking to each other. Honestly, that's the biggest hurdle that we have. Usually the conversation around data quality is kind of the last thing you do when you start integrating. It's, oh, do you have this? Do you have that? Okay. And then you start running through your processes and like, oh wow, they are using totally different code sets, or they're just something here that we didn't expect. So talking ahead of time, I think, is the biggest hurdle that we have to get to. You do have to start looking at the standards, right? The standards at least give us a foundation on which we can work upon. So the fire community has done a lot to standardize. The implementation guides have really taken another step. There's challenges with the IGs because those are built in silos. They don't work well with each other. So they need to start working together, and that's where conversations have to happen. Like if you start talking about BSeers, someone was talking about the referral management and sending clinical information. You have to make sure BSeers is working with US Core. So not to nerd out too much, but we have to start talking and making sure that that full experience that you're talking about is happening, right? Like if we don't, the data quality is going to go downhill, and then we're going to start building AI models on top of that really bad area of non-clinical models. So it's going to be a challenge. We have to talk.
And I think sometimes it's the baby steps, isn't it? Those important foundational baby steps. We use the national standards for data maturity model. So we're starting to assess ourselves against that maturity model, various parts of the business. And we range from where really we are very immature to where we're sort of middle of the road. We're definitely not at full maturity, but it allows us to start to bite that off and make it very clear to people and our workforce where we are. And then also bolting into that the national quality standards. So get your upfront design right first. And if it's good enough, yes, it can go in. Let's make it really straightforward and easy for people to do. And we found the shift of data being precious for many reasons. It's precious to your customers and your patients, but also it's very precious in terms of what we can benefit the end user with. So it's a shift in cultural piece as well, but the frameworks really help people see what it is in our organization, what we're trying to achieve, and that data's not boring. And it's absolutely right to get the basics right, because then we can go faster ultimately.
And I would say being humble, right? One of the things I constantly say to our data teams or to a creator of information on our side is that you're not special.
Yeah.
You're just not special. Tell me why you need to have the data in this format. I don't know. I'm like, you're not special then. Okay, let's just use it. Let's use the standard. But it doesn't work for me. Why? And I just get blank stares. I'm like, okay, so you're not special. Let's move on. So that's being humble and actually being able to hear that. There's no reason for you to have to create something custom.
And I don't think we should be too worried about AI in certain circumstances. I think there are places where you can test it.
Absolutely.
And see just how good your data is. Actually, we've done a bit of a REMA model with some forecasting of how close are we to our predictions of where we're going to be using an ARIMA model. And actually, we thought our data was rubbish, but actually, we got quite close. So in certain circumstances, it's quite a nice test and learn environment. I just agree with you. I don't think it should just be unleashed across the piece. So I think test and learn with AI is quite a neat way to go, and we've certainly found that's very useful.
We're doing some scorecards. I mean, that's not going to be an end-all, be-all, but starting to give back to the provider institutions, because certainly how they set up their EMR, as many people have said, the great things about standards is there's so many to choose from, and so they choose whatever standard and then they tweak it, and so then you have to do some things. But even just the quality of the data and the clinical note that's coming across that we as physicians put in, and we have seen some significant improvement in just the clinical notes with the open note movement when patients could actually see their notes. And some people, unfortunately, have gamed that a little bit, and you're seeing abbreviations. I was looking at a chart the other day, and I was like, what are these abbreviations? And then it was pretty clear it was kind of internal lingo that they were trying to communicate to the other providers, but they knew that the patients were going to be looking at it. So we'll have to work through some of that gamesmanship. But I do believe that, the conversations are critical. But then some scorecarding of, okay, A, you have to send us data, and B, your data's trash, or insert better word. And here's what we're seeing in that. And so, and then eventually over time, if we do get to a world where, let's just say we're paying for health not off of claims, we got to get that right. And so we need to start saying, okay, if you don't put in the bill right, theoretically, you're not going to get billed. If you don't send the clinical data the right way that makes sense, then you're not going to get reimbursed. And so those types of things are important going forward.
And I think back to the example I shared before of the health plan that was paying incentives for sharing data. As the implementer of that, as the HIE, we had an Excel file that was basically all of these fields have to be included in your ADT, your ORU, the CCDA we did was like too much of a mess. We didn't get to that yet. And it was so interesting because we would then see these conversations going on between the IT team and the CEO's office that had never happened before, where the CEO's like, we need our incentive payment, and the IT team's like, well, you haven't upgraded our system to allow us to we actually need to rebuild these fields and these feeds altogether. So it was a really, but it was very precise. I mean, you can't kind of improve quality by being a generalist about quality. You have to say, well, our priority is the ADTs. The ADTs are our priority because of this business driver, and these are the fields we need to get to that use case. And then now we're going to pay the incentive. So it's like anything else. You kind of, you do what you're focused on measuring. Okay, let's talk policy a little bit, and I'd love to start with you because you mentioned policy, some of the changes going on in COVID, and I guess the question is, and maybe focusing on national policy for a minute, where do you see policy speeding up your success right now, And where do you see policy as a barrier?
Well, I think it's more the access to the healthcare data, and it's just the overall policies on how we will care for people. And it's great to see the changes in CMS and realizing that there's so much beyond just health care, right? That it's really health, and how can we enable people to stay and live in their homes. I don't know, many of us probably have like aging parents, right? And I think that's one of my biggest fears we both lost our fathers, but my mother and mother-in-law would have to leave their home. So how can we help them live better lives, connecting them into home and going beyond just healthcare, right? How can you really, like, using data, thinking about policies, how can you like avoid the falls? We spend $50 billion a year on falls in the US, and if we can avoid those falls, and many times people fall and they lay on their floor for 2 to 3 days, right? So how can we, in the policy, the things are there, like we have these emergency response buttons, and the payers, they're like, if you have Medicare, you can get one, but it's like so many people don't even know. Like Elevance has 1 million people on Medicare, and only like 5% of the population know they have access and actually have these devices, and think if we could make it 50. So I think, I don't know if this is policy, and I'm not really a policy expert, but like how can we change and just like at the end of the day, do the right thing. Like do the right thing for our people so that they can live healthier lives in their home, and then make their home a healthy, healthy lifestyle where they can, be happy as well. We have caring centers, and people call them. It's just amazing. Like this tech can help, right, with NLP and other things to tell if people are very lonely or depressed. I mean, you think about it. You lose your spouse after 60-something years, and you don't even, you're not even getting groceries. Yeah. So I think just policies should just be more innovative so that we can, spend the money on keeping people healthy versus spending the money on getting people into the hospital. Like I was at Fortune Health, which is really an awesome conference this year, and someone was saying how like with food stamps, you run out. There's this woman, she was brilliant, but she had been a single mom on food stamps, and you don't have enough money to be healthy, and there's those health deserts everywhere too, right? She said what people do is they go into the ER at the end of the month because they can't afford, they're hungry, and they need warmth, and they go in the ER. And what's that visit? Like $10,000 probably just for an ER visit. How much food is that going to buy? So I think policy's got to bring in innovation, because the tech is there, but be innovative on how we can help people live better lives.
Great answer.
Yeah, I agree. The regulation is starting there, the tech is there. It's making sure, and CMS and ONC have started focusing on this around putting the patient in the middle of the information, right? Making them the hub and be able to share the data out. What we have to make sure, though, is from a regulatory standpoint that CMS and ONC continue speaking the same language in terms of what they are trying to accomplish with the policies. Because you have the current CMS proposal that was out, I think it came back out in December. And then you had ONC came out with HT1 back in March. And there's a little bit of disconnect between the two of them. We have to make sure that they continue speaking the same language and they're proposing the same concepts, because what happens now is that you have states like California and Washington who are now picking up the federal side and applying it to the fully insured businesses, because those the federal ones only impact Medicare, Medicaid, CHIP, and the federal mandate ones. So you have to make sure that we keep ONC and CMS kind of in sync in terms of what data is available, and then also looking at how can they incentivize, whether it's through monetary actions for not actually making data available, or incentivize for some creative new pattern for exchanging data that actually gets a patient in front of a healthcare event before anyone else knows about it, right? I think there's a lot of opportunity there, but as long as we keep the regulatory agencies speaking the same languages, that's critical for us.
Yeah, I think there's caution too. there's so many things as y'all were starting out, I was like, oh, yes, 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 yes. And then, also thinking about the real world that many of us have to live with, of what are the unintended consequences of those and what is the timing of the policy. Many times the policy, we know what needs to be done now, but it takes so long for it to get actually implemented. And it's good that we have, the public response back and everybody gets to say something back in. But then frequently we found that that's actually moved the needle a little bit, and then we can go on to the next thing, and then we don't have a policy sitting on the books that we got to get rid of. And so, I mean, it's good and bad. I know it sounds like I'm speaking out of both sides of my mouth. It's just tricky with how do we put these things in place. And then sometimes there's some policies we have that you mentioned where we need more teeth. We need some, don't get me started on transparency if you've seen the things that are out there on some of the transparency websites. AI, I'm sure we might get into that a little bit, the United States versus across the pond and the EU, to make sure that we have the ability to continue to use it before someone comes out and does something terrible, then it's shut down because of reactive policy. Those are, I guess, all the different things we got to think through. It's hard just to say. None of us in this room, if we all came up with one policy, I guarantee you we could not get consensus to go after. So it's a challenge.
I'm going to ask one more question, and then we'll move to all of you. So, and I think I'm always struck by the personal stories that brought us into this work, and often keep us going when we're facing something challenging or hard. And I'm just curious what your personal stories might be that you keep in the back of your head to bring out when you have to remember, like, why am I doing this? Anything from your lives that keeps you going?
Yeah, there's two sides. One side is a personal side with my brother. He had hip dysplasia from a young age. I think it was 11 or 12. So he's constantly in and out of the hospital trying to get his hips fixed. And it meant going from a local hospital down to CHOP down in Philadelphia. And my father and I always have to go pick up the images from one place, bring it to another place, pick up the doctor notes, and then you go to the doctors up home for a checkup. And like, we didn't know he had surgery. And it's like, so it was just constantly running back and forth. And we're talking, in the 90s, that's a lot of information that was in binders or in, floppy disk or just the physical images. So that's something I always keep in my mind, is like just having that information readily available would have made my parents' life so much easier. And then the second piece is, one of the big philosophies I have for work is I love to do chairside visits, whether it's with a clinician that is working at a desk that's just calling up someone saying, hey, how are you doing? We saw you were admitted to the hospital. Or a provider who's actually going in home and going to the visits. That was probably the most enlightening experience I've ever had in my life, is just someone who's going into Northeast Philadelphia for a patient that hasn't left except for to go to the emergency room. And seeing that from a provider perspective and from a patient perspective, it's just opened my eyes. I'm like, oh my God, there's a lot we have to fix in just this little pocket. So that keeps me going.
Thanks.
Mine's my dad. He had congestive heart disease. He was a vibrant man. Everyone loved him. He had been a principal, a teacher. But in the end, his last 6 months, his heart, it's a muscle, right? And it was just wearing out. And I knew the whole time. He had 3 hospitalizations during COVID. 2, my mother couldn't even go see him. He stayed for more than a week just to be managed and monitored. And I knew the whole time, like, tech is here. Like, this is not that hard. We should be able to have him home. With all of us being able to take care of him. And the last month of hospice was terrible because we couldn't, the visiting nurse comes twice a week and he's getting worse and worse. And I just thought the whole time that I knew the monitoring was there. I'd worked at Philips for 5 years. And so I knew. And it was funny at his funeral. After his funeral, he was a veteran, but we had taps and everything at the Veterans Cemetery, and I got in, and Deborah DeSanzo, was the CEO of Philips Healthcare, now is the president of Best Buy Health, sent me a text. So I was like, I think my dad's trying to tell me something about, could I have time to talk to her that week? So I'm here because there's so many dads out there, moms, children. There's so many ways that we can help people and their caregivers live better lives better lives, even when we knew he was going to die, but it would have been a better experience for everyone, ultimately him, but everybody around, because it takes a village to care for people who are not well. So that's why I'm here.
I'm very similar to your kind of experience, Jean. I'm a nurse by background, and I always wanted to care for people. It was from a very, very early age. And what keeps me going is the impact that we can have on people's lives at a very, very simple level. And I'm quite a simple person, and I like getting things down to their simplest level so that they work, and that they work en masse and as a bit of a movement, so we can enact change that way, because simple things make huge differences to people's lives, and we can make the world a better place, quite frankly. So that's what keeps me going. Even when it gets a bit tough and a bit hard, it's actually, we are the driving force for making the place better for people, and their experiences through life, and also the people I work with as well. How do we make that better? What shadow do I cast? And I think about that quite a lot as well.
So two, I'll be real quick. First one, the CVS guy kind of stole a similar story. But my daughter, I was working in the emergency department. I'm an emergency medicine physician. And I was a third year and was working in the trauma bay that day, and actually got a phone call from what I thought was my wife, which was weird because she knows she's not supposed to call me at work. Like, she never calls me at work. And I was back in the day where it never works in the emergency department anyway. But it was our pediatrician, who was a good friend of mine, who had graduated med school a few years before me. And I could hear my wife crying in the background. And it was like, okay, this just got real. What's going on? Fast forward, daughter was fine. She had, ended up being just some atrial ectopy where she had an irregular heartbeat. But the thing that really drove me crazy is I was still in training. You couldn't miss work to go to doctor's appointments. That sounds bad to say, but that's just the world, in training that we grew up in. And I could throw a baseball from our emergency department to the pediatric cardiologist's office, but I couldn't get notes back and forth. And we were the same health system. To me, that's just stupid. That's just dumb. So that was the first kind of The second one was actually transitioning over, and I had worked at DHHS for a while with Medicaid, and then went to BlueCross coming up on 5 years ago. And one of the first times I sat down within the first 4 months with a large national employer, I had no idea what I was doing. I knew I was supposed to kind of go through some of the clinical stuff and answer questions and pontificate as the physician, right? And someone came in that wasn't expected, because the team was sitting around, and so everybody was there, and I'd studied. I knew who was whom. And then some gray-haired guy walked in the room, and they stood up and slid over. And I was like, oh, I don't know who that guy is, but he must be important. And he sat there through the entire meeting, which was like a 4-hour annual review. Never said a word till the end. At the end of it, he said, Dr. Jennings. I was like, yes. He said, so you have a bunch of data, right? I had already been going on and on about all the data we had and what we're trying to do with it. I said, yeah. And he said, do you know so-and-so? It was just a random name. And I said, I don't think I do. And he was like, well, he was one of my AVPs. And he was my best friend. And he went to a hospital that he should have never gone to. And you have all the data to prevent that. And I sat there and I was like, I still get chills thinking about it, because here I was thinking this is going to be all, puppy dogs and kittens. And he's right. Now, it's not that easy. We all know that, because there's a whole lot of things that go into that. But he's right. In theory, we have or can get that data to help people get to the right place. And that's when I realized it was personal, not only to us in this room, but it's personal to others out there who are paying for this, and it's their employees, it's their friends.
Yeah, wow. All right. I just think it's so important to come back to how this touches our lives personally. We have a couple minutes. I have a question for Kathleen. Can we go a couple minutes over, or no?
Cuts into the break, so yeah.
Okay, we'll take a couple questions. We'll try to stay on time. that was couple comments or questions.
Gigi's running.
And maybe try to make it quick.
Claudia, it's Michael Marchand again. So one of the things that I find interesting is we talk about ADTs and ORUs that are 20-plus-year-old standards. So in the future of interoperability, at least in the marketplace and everything I see everywhere, is everything's going to be fire-enabled. So can you talk through, any of you, strategically, how your organizations are looking at the fire standards and how you'll get data for your organizations leveraging fire, since it's a request respond as opposed to a push methodology?
Sure.
And-
Well, maybe stop there.
Sure.
And one person can respond. I think we have time for.
I can respond to that, it's just not a short answer. So maybe we can talk afterwards, because there's a lot of information around that, because using fire as a standard, there's a lot that still has to go into it, and you can shift the technology a little bit to be more than just push versus pull. So we can chat afterwards.
Happy to talk offline. Just,
We'll have a little cocktail corner.
It's a great question.
Dinner.
It's a really good question.
It
It's
is.
just not
Yeah.
a 2-minute answer.
Yeah. Any other? Thank you.
I'm over here. So my question is about the data quality, and particularly in healthcare environments, you have a lot of manual inputs of that data, whether it's a CT or an MRI or blood collection. The quality of those inputs is notoriously unmeasured.
Yeah.
Are there plans to change that in an effort to have cleaner data?
So you're talking about taking something and then hand entering it? Is that what you
No,
meant
I
by
mean
manual?
like running it. So if someone performs a CT, there is a gradient of the quality of the CT. So do you measure the quality of the inputs so that you have cleaner data?
Does anyone have, I'm wondering in the home environment, have you looked at that?
Well, in the home environment, it's connected. We have a connected platform.
Yeah.
Well, I mean, you still have the blood pressure monitor, right? I mean, those things are tricky, in my opinion, but you still have to manage it and make sure that, that it's set up right.
We have lots of monitoring, national standards, and we have to have independent, validated reports on, what our kit is doing. So those inputs, and that's annual.
It's a great question, though. Yeah. I think we are going to have to wrap up. This has been great. Sorry we didn't have more time for questions. There will be a future of fire and data exchange in the corner of the dinner tonight, I think, over drinks. Thank you all so much. Thank you to each of the panelists for joining, and look forward to continued discussion.
Thank you.
Thank you all.